We'll make a start. So welcome, Monday the 28th of April. Hope you had a lovely Easter break. Thank you for joining us on this first day back after the school holidays. So I know quite a few of you, this will be your first day back. We are presenting today from three brilliant speakers, but just to cover some of the housekeeping in advances, don't forget to keep your sound on mute if you can, just so it doesn't disrupt any of the presenters. And we are recording the session so that we can circulate after the event. We know that there's many people who are unable to join, so they like to listen in afterwards. You can switch on your CC captions at the bottom of the screen should you need it. And please do use the chat function throughout the session, for the chat function, I'm sorry I've got the wrong name on there because Leanne didn't join us last time, but Leanne's going to monitor that throughout the session. So for those who haven't met myself, I'm Rachel Forbuster. I'm a Digital Transformation Programme Manager at Health Innovation North East North Cumbria. I've led the Digital Inclusion Forum for the last 3 years, bringing together people who are interested in understanding some of the challenges, but also how some of the top tips to overcome some of those challenges. And we have an array of brilliant speakers who give up some precious time to come and share their input and their insight into what it means to them. We're one of 15 across the country, introduced by NHS England in 2013, around spreading adoption of innovation and how we do that at pace where it's possible. But we don't just do that, we connect and do lots of different things. So we have partners with academia, NHS, we do a lot of work with different innovators, but we also look at what the third sector's doing, how do we support them, as well as how we understand regulation and lots of different things as well. Some of the 3 core objectives are transforming patient safety. It's also about improving the health of the population. But the final thing is around how we generate economic growth through working with local innovators and looking at how we can spread and adopt some of their own ideas and technology. So today we're joined by Julie Pike from the Poverty Proofing team at Children North East. We've also got Chrissy Voller, who will be helping to share the Boost learning platform. But firstly, Dr. Martin Weatherhead joins us from Bridgeview Medical Group, but he's also the chair of the DPEN network, as well as the clinical lead for the Growth Accelerator. I'm going to shut my slides down and hand over to Martin.
Thanks, Rachel. I'll just switch to sharing my screen. Before I did this role, I was working with Rachel pre-COVID. Now I think it was on a digital monitoring project, which was looking at managing high-risk patients to try and prevent them going to the hospital. And right from the beginning of that pilot, it had digital inclusion as a real core principle for what we were doing, and that included we provided the hardware to each of the patients. We worked very closely in collaboration with the local authority, who had a training function and went out to the community to then teach people how to use the technology. And the technology was Wi-Fi enabled if you didn't have it. Sorry, it was SIM enabled if you didn't have Wi-Fi. So right at the beginning, we sort of include digital inclusion as a core part of what we do. And as a GPEN working in the sort of practice I work in, digital inclusion is something that we always think about, but probably don't then implement as often as we should. So what some of my other roles, previously the co-chair of the Broader Determinants work stream, which the digital inclusion had a reporting line into that, although I know that the strategy was done elsewhere. But I'm going to tell you a little bit about the DPEN network and what it means and what it is and how it's defined. And I'm sorry if you've seen some of the slides. I'll rattle through the slides fairly quickly. But then I'll also tell you a little bit about the Growth and Health Accelerator. So, now, first moment where I'm struggling with the technology. My slide's not moved on.
So if you just click back on the screen, and then if you use the right-hand arrow, Martin. There we are.
I've got it. So the DPEN network was really set up to build on the work of Julian Tudor-Hart, who was a GP in South Wales, and he coined the term the inverse care law, whereas the availability of good medical care tends to vary inversely with the need for it in the population served. And as a response to the inverse care law, the Deep End network was set up in Scotland. It was began in Glasgow in a research in the university, and it brought together the GPs serving the most deprived communities. And the founder of the Deep End network in Scotland, Professor Graham Watt, talked about GPs working in areas of deep blanket deprivation as having to tread water, hence the Deep End. And again, that original graph reflected the need of the population, looking down the different groups of workers, the need for medical care as opposed to the availability of it. It's now spread into an international movement with Deep End networks all over the country, but also internationally now in Australia, in Canada, in Japan, and Denmark. And it's an international movement, and there's international conferences every couple of years trying to spread the work of the network. And the fundamental aim was originally to change the way primary care is delivered and for wider systemic change in healthcare funding. So we set up our Deep End network in 2019, and originally the two main things are to support the Deep End network of GP practices because they tend to have lower resource allocation to meet patients with the highest complexity or the highest proportion of patients with high complexity. And we wanted to support high quality, sustainable and resilient general practice in the Deep End to address the inverse care law by advocating for proportionate universalism, and to work collaboratively to change the way that primary care was delivered so it could produce positive changes for practices and communities, and hence improve population health outcomes. But we wanted to be a member-led network focused on practice-based priorities in the hope that those practices then reflected the population health needs of the communities that they looked after. So we originally followed the definition in Scotland, which was to take the proportion of patients living in the 15% most deprived LSOAs nationally, and then bracket each practice into deciles as to what proportion they served, with the highest proportion of patients living in the most excluded, marginalised socioeconomically communities being decile 1. We then redefined it to make it a little bit easier, so that it was to be for where more than half of the total practice population were living within these neighbourhoods. There's a few graphs and I'll just rattle through them quickly, but they're there as much for information as anything. This just demonstrates what the demographics mean, and what it is that even though we look after a minority of the total population who are looked after within North East and North Cumbria, we still look after a significant proportion. So it's about 15% of the practices are Deep End practices, but they're looking at around about a third of the total population of Deep End patients, and 30% of the core 20 population. And just some of the basic challenges that are facing practices so that you can understand a little bit of the context for that. And this is now looking at those practices ranked in deciles according to the proportion of patients that they look after who come from the 15% most deprived LSOAs. And what you can then see is this standard presentation based around practice populations to A&E, because urgent emergency care is always a big political issue for the health service. We've got very similar data for readmissions and emergency admissions. But what we decided to do was to sort of change it around a little bit and get the data then defined according to what actually happens to the patients from those 15% most deprived LSOAs when you look at the same data, but only those patients. And then what we found was this is nothing to do with the practices. The presentation rates is defined by the population that people look after, most clearly by the deep end patient population. And the only real variance in terms of the amount of presentation, the highest presentation rates, that is for practices who look after the most affluent patients. When you look at their patients from the poorest parts of the country, their patients do worse than the patients from the poorest parts of the country who are looked after from practices within those communities. And this might be a statistical anomaly because it's very low numbers of patients, but it's an interesting finding which sort of mimicked what Marmot found when he looked at how school children performed. And he found that patients who went to school from the poorest communities to schools in the most affluent communities did, on the whole, did worse than patients from the poorest communities who attended schools within their own communities. This is a bit more about inequality and the impact of inequality, and this shows IAPT completions, treatment completions. You can see that there's, approximately twice as many referrals from the poorest decile as compared to the most affluent, and the completion rates for treatments are fairly similar, and that's because of all the different impacts that and barriers that we put in terms of completing treatment for patients. And this is for low risk patients, low intensity interventions. When you're moving into the practice population or the patients who have the most complex mental health needs and the most complex interventions are required, we haven't got data for it, but the expectation is that the completion and referral rates are even worse as a proportion of the population. And obviously this is where the impact of, among other things, digital exclusion can be seen because of the way that we communicate with our patients, choosing communication forms that aren't their chosen ones, or not taking account when they don't have access to the communication channels that we choose to communicate with them via. This looks, again, some work looking at the patients from the deep end patients compared to all other patients and the incidence of lung cancer. And if you think that the targeted lung health check is now based around the premise that we want to catch people at an earlier stage of their lung cancer, and we start screening at 55 to 60, what you can see is there's a 5-year incidence shift for the poorest patients. So are we starting at the right time? That's assuming that we can get all these patients to go to their screening anyway, because again, the impact of literacy, digital exclusion, and unpredictable lives, which are more impacted by unexpected events, such as having to work because you might lose your 0 hours contract. So then at the last minute, not being able to miss work to go for a planned care appointment. So what have we done as a deep end network? We've set up a whole series of pilots, and I'm going to preface this with the confession that I don't think we've done an awful lot in terms of digital exclusion or digital inclusion. I think that we have attempted in each pilot to take account of it, but I don't think we've done specific pilots focused on digital exclusion. So we looked at an immunisation catch-up team which roved across the whole of the ICB, trying to get patients who are part of practices with a more challenging demographic in terms of accessing immunisation. And they have rotated across the region to go to a practice for a couple of weeks at a time. We've run the pilot for a couple of years. We've had some changes, got some learning from that, but moved on. We've embedded psychology to try and address some of the issues that we talked about in terms of completion, de-prescribing and opiates, because obviously there's higher rates of chronic pain and higher rates of opiate prescribing. And we've started to get some link workers involved to try and that's 42 pilots right across the ICB, trying to address specific health needs of populations in practices, such as improving the uptake for screening, improving the optimization of management of certain conditions, often aligned with Core 20+5. We've really try to increase the number of GP training practices for those serving the deep end population, because we've got much lower rates, and we know that recruitment and retention, which is the other big issue for deep end practices, is better in teaching practices. So we've developed a roadmap to try and encourage people to get interested in deep end medicine at an earlier stage. And then we've done some specific pilots, including fellowships and the Train Deep, to try and encourage people to work in the practices. We've done our advocacy and engagement, and everything we've done has been underpinned on the basis that research is needed to understand what works better for the population, and then being able to demonstrate that the things that we do have had an impact in terms of outcomes. So we know that we immunise a lot of patients who didn't have it. We know that in my practice already, in the first phase of the Care Deep pilot, that 82% of patients from my practice are attending targeted lung health check, which is higher than the average, and this is for a population which historically has not accessed planned care. So the other main bit that I do, and I think there's a lot of overlap, and that's the Health and Growth Accelerator, which you may or may not have heard of. Just to give you a little bit of a background, it's around the government policy to try and improve employment rate and to reduce the health accelerators, are focused on trying to reduce economic inactivity, which is a response to health conditions. It's backed up with a whole load of other policy initiatives which are being run through the combined authorities. So the North East Combined and the Tees Valley Combined authorities are both running pilots. Youth Guarantee, there's lots of different strands are being developed to try and address the economic inactivity. But the health one is very much around making sure it's embedded into the whole system approaches. And where we are slightly different, we're focusing more on those patients more at risk or in the early stages of economic activity, but not excluding them. Whereas the Combined Authority, North East Combined Authority, is focusing a little bit more on those people who are more entrenched in terms of economic inactivity. There's 3 nationally, 2 in Yorkshire and ours, and we were awarded £19.4 million to improve population health and reduce health-related economic inactivity. That's a lot of money, and 1.49 of it, 1.46 of it, sorry, was for digital solutions, specifically for digital solutions. And the digital solutions, HNENC are running a project call, a national project call, and the applicants for that are being assessed currently to see if there's some innovative digital ways to reduce economic activity. What we know, the main drivers of economic activity in our region are, by far and away, the largest group are mental health problems, followed then by musculoskeletal disorders. There's often a lot of overlap between the different areas, but mental health and mental health conditions are the #1 clinical priority in the deep end. And as we know in the clinical condition strategy for the ICB, it's also a big area of prioritisation for targeting interventions and resource. And so what are the pillars of our accelerator programme? I'll focus mainly on the person-centred early intervention and prevention ward. There's also the supporting the health and care workforce, which is extending the mental health and wellbeing hub, which is currently commissioned via NUTH, but provided through CNTW. And then there's also the promoting good work and employer liaison, which is to do things like developing the neighbourhood model promise to maximise the role of anchor institutions. And it was in that part of the broader determinants work where we thought digital inclusion could be have a really core impact, so that we start setting what we feel could be an appropriate task of large NHS institutions in terms of including digital inclusion as a core part of what they do, and to take account of that in line with their actions and other things like their action on employment, being a good employer and providing employment opportunities for people from more marginalised communities. But the person-centred early intervention part of the accelerated programme is using population data analysis to target those at risk of economic inactivity. So it's using a retrospective data trawl to try and find patients who had a couple of sick notes in the last 6 months, including an active one, and then referring them in through GP practices, potentially, into the waiting well hubs, so that then they can access local resources to help overcome the barriers that they have. Now, we need some locally led commissioning, obviously, to enhance the availability of work coaches to provide the biopsychosocial support model that we have recognised as being one with the greatest chance of success. And that's built on some patient advisory service work, which is being done in Durham and Tees Valley by the Department of Works and Pensions, where GP practices have an embedded DWP worker who uses a GP records, who is directly referred to by the GP practice, who can then break down the barriers and some of the concerns that patients may have about getting them into, about seeing a DWP worker. And then they work through some of the barriers, and they can work with someone for a couple of sessions, and in some cases for years, just slowly addressing the health-related and social-related barriers for them returning to work. But what we also know that the inherent waiting lists, particularly for mental health services and MSK services, contribute to some of the delays in accessing. And so we're looking at enhancing access to therapies as part of this work. I'm not going to go into this in detail, other than to say I've mentioned already we've got to harness the opportunities that being an anchor institution offers as part of this. But also we've got to ensure that our Core 20 and inclusion groups are proportionately represented in the population who then get the additional support to overcome the barriers to work, because we know that some of the largest proportion of patients are from these communities anyway. Oh, excuse me. Forgot to turn that off. Almost finished, Ruth. Hopefully left enough time for questions. Oh, what have I done? I've pressed the wrong button. No, I haven't. I have finished, in fact. So I'll stop sharing my screen. And that was a little bit of a really rapid run through, and there's quite a lot of slides, but I hope it made sense.
It did. Thank you so much, Martin. I've just put a spotlight on you. We've got a few questions. We've got a couple of that we've had in the group chat as well as myself, obviously having some noted things. I think the important thing for me, I know you work Southwick and living in Sunderland, I understand some of the demographics of some of kind of the areas within Sunderland, I would say. What I was interested in is how you got involved in the first place. Was it because you were interested, or was it because you saw the challenges within your own practice?
I mean, I think it's both. I think that I don't think you can grow up in an ex-industrial northeast town and went to a local school here where none of my mates, when they left school, got jobs because the shipyards and the pits all closed down and there was hardly any work. And then when I came back and started working here, then you could see the impact. You could see the impact of a lack of good work from that time in the 80s, which then was a little bit overturned by some of the economic development that happened in some, particularly Nissan. So seeing those broader determinants is something that I saw every day at work. And I also saw the impact of long-term worklessness on whole households, and realised that it's not just people not wanting to work, it's all the problems that they have make work really difficult sometimes. It can be very difficult to sort of access work. There's a lot of barriers to it. But I also saw so many of my patients then not going to appointments, but they weren't going to appointments often because they had things that were more important to them at the time that they had to do, or they couldn't afford to get the bus there because it's such a nightmare to try and get, the funding to get to appointments. So for me, it was just seeing it constantly every day, hearing how difficult people's lives were and thinking, you know, my job as a doctor, a lot of what I'm doing, a lot of the mental health impact that people are trying to struggle with comes from the lives they're living and the challenges that those lives then create for them. And the insecurity of everything, the insecurity of their work, the insecurity of housing, the insecurity of everything. And then we, as a health profession, we just communicate in a language that most of them don't read because of their health literacy ages, or using technology they don't have. And it felt to me that we weren't really meeting their needs. And so that's how I became more interested in doing the different things. I set up a drug and alcohol service because I could see that there was a lot of inequality there. But I think really for the first time, the health service is really taking inequality seriously and really understand that if we don't address that disparity of outcome, we'll never address the whole population outcome performance that we have as a whole system, which is poor compared nationally, not because we're bad services, but because the way that we focus and how we focus our services aren't meeting the needs of the population we look after.
Mm-hmm. Always a challenge, isn't it? I knew some of that already, Mark, but I wanted the audience to hear some of the reason that you've kind of fallen into that. I think it's really important to understand your passion. And as I say, I live in Sunderland. I see that every day. I live near Pennywell, so I'm in a fairly deprived area. I'm a governor at the school, just to try and help that community. I think it's really important. A couple of other things. How many deep end practices do we have in North East North Cumbria?
We went from I think we went from 34 to 52 when we changed the definition, because what we found was that there's some practices with very high proportions, like there's some in Walker who've got 90% of their patients live there. Practices like mine is 66%. But a lot of the practices were all hovering around that sort of 48 to 52%. And there was a lot of movement potentially, and we wanted it to cover a larger population, so we changed it to the 50% definition. And then once you're part of the network, you're in for 3 years, because they update the statistics every year, and then they update the national statistics because it's all built around LSOAs. That's due for a review this year, so it's to try and stop that. But there's 52 practices now.
I'm assuming that we've covered two of the comments in the chat were around Teesside, which I would expect just because of the high levels of deprivation, and Durham because of you've got your outliers with the smaller villages. So I'm assuming we will have. So just to answer the questions, obviously in the chat function there, that we would cover each of those. But 52 practice, I think, is fairly big, isn't it? It's we've got 350-ish approximately. So we've got a fifth of those practices who are being supported through that deep end network. We've had a couple of more comments or requests. The data was really interesting. We have somebody who's doing their masters and somebody who's doing their PhD, and we're hoping to get a hold of some of that data. So if Leanne connects to you, Martin, I'll be able to get some extraction or wherever that's come from, or a signpost that we can pass it on to those two people. Yeah, that's
absolutely
brilliant.
I've got lots more data. I've got loads more data. So if they want a sort of a fuller data set, I didn't want to bore everyone. But if they're interested in the data, I can send them a more comprehensive data set. So if you just let me know.
I generally find our academics are very interested. The more data, the better. So that would be great. One of the questions from Mike, who kind of does patient representation, is around the social prescribers that PCNs have. And is there a good, strong linkage with kind of the deep end work that you do and looking at your ambitions?
Yeah, absolutely. Social prescribing is an absolutely crucial part of it. But the big risk with social prescribing, we're seeing it already, is the new GP contract, which is allowing more flexibility to use the DES part of our contract funding. So I think what we're seeing is a lot of practices and PCNs starting to withdraw their commitment from social prescribing. And that's something that we've got a real concern about. In Healthier and Fairer, which is the subcommittee of the ICB that looks at inequalities and prevention and the broader determinants work, as well as the Work and Health Accelerator, we have that down as a risk, because as a formal risk, because what we're hoping with these pilots, Mike, is that what we know is that we all think it's very, we all think that it's a proven case, but actually the evidence base isn't as big as you think, which is why these 42 pilots that we've got running are so important. And what we're hoping is, by demonstrating the impact, because it's often social prescribers and link workers who are getting the additional, because it's not for professionals, this as in medical professionals, the pilots are for social determinants workers. So it's to break down some of the barriers with communities, to enhance the way that we communicate with communities, to take account of health literacy, to do additional chasing to accept and understand the barriers that people have, to try and break that down. And so we're hoping to build an evidence base which will get PCNs to reconsider where they have already started to withdraw their funding for social prescribers, but then to think about, actually, should we go back into that because we can get better outcomes by doing it? But it's a big challenge and it's a big ask to demonstrate that, but that's what we're hoping for. We know, as a network and as doctors who work in it and professionals who work in it, we know the vast majority of social prescribing resource is in the community and nothing to do with us. Ours should be additive and additional, and it should never compete with the community resource and the community providers. This is a separate additional thing that we invest in my opinion. That's how it should be. And it shouldn't be another service that's competing for scarce resource from other sources. So I think GPs have to, but I'm not a voice here of my colleagues, because I think we have to make that case. Part of what we do in the deep end is always to try and demonstrate how it can, what we do, demonstrate the impact, but also build in potential sustainability. And that is either because we make a case for commissioners, health commissioners, or because we make a case to practices to say, actually, it is worth my while contributing to this because the return I get can be covered by that.
I think there's so much evidence around social prescribing, the whole reason that they've invested in that. So I think that's quite disappointing to see some people withdrawn. And it's kind of really looking at, well, what's the purpose and how do we add value and how do you train? But how do you signpost and work, as you say, with the community? Because that's generally where the goodness happens. And the person in the practice is just the person referring in or recommending and looking holistically at that person and thinking what else can help them. So I think it's a really good point, Martin. Going to pick another couple of questions out of the chat before we let you go back to your busy day. We've got Sue, who's mentioned about a family member who's been jumping up and down, as her expression, about a notice in the surgery that said about missed appointments and how they would be fined. I'm wondering if that is it helpful and does it change perceptions?
Oh, I'm sorry. Look, again, I can't pretend to be the voice of my profession. Right. Okay. I think it's ridiculous. Look, the bottom line is we've got to understand why people miss appointments, and we're all humans and we all can potentially do it. But you often miss appointments for the things I was talking about before. People miss appointments because we are asking people to go to appointments for things that we think are important. We mightn't have persuaded them that are important for them. And you're talking now about things like vaccinations or screening or or optimizing their blood pressure control or their diabetes control. The fact that we haven't managed to persuade people that it's really important for them, because it's that whole what matters to you, not what's the matter with you approach that we think is much more important. The fact that we haven't managed to, well, that's our fault, in my opinion. So if people don't turn up, I want to know, what is it about my appointment system that stops people coming? And so I think, yeah, how can you find people? I mean, it's not for me. I think it's crazy. I'm not sure that legally you can anyway.
Probably just an idle threat.
Yeah, and I mean, but why don't you find out why people have missed appointments and accept that sometimes people's lives are just difficult and there might be really good reasons. Somebody might have been about to leave when something happens and they've got to stay because if they don't, their housing officer is going to start with, eviction proceedings. You know, we've got to understand people's lives before we start fining them.
Definitely. So hopefully that's answered your question, Sue, or a perspective, of course, not the majority. And the final question is from Siraj Mohammed, and it's about unheard of or not often heard of communities, and it can cause, lots of challenges. How do we tackle that? How do we support them with digital when we aren't hearing from them? And we do have pockets in Sunderland, I know, and understand that. What's your kind of thoughts on that, Martin?
I'm really sorry, I got distracted by a couple of the messages. Sorry, would you just repeat the question? My apologies.
Yes, Siraj is talking about, kind of the not often heard from communities, and that could be language barrier or education, and their issues seem to be much more compounded. So how are we tackling that? I guess what's your thoughts on that?
Yeah, I mean, and I think I really like the core 20+5 approach. You know, it's a government policy, and the government finally said, let's look at what has the biggest outcome difference in the most affluent and the least affluent communities, and which has the biggest difference for the inclusion communities as well. And so, yeah, there's lots of communities whose voice isn't heard. The deep end is pretty much about socioeconomic exclusion, although socioeconomic exclusion goes hand in hand often with some of the inclusion characteristics like ethnic minorities or learning or physical disabilities or neurological diversity. A lot of these things all go hand in hand. But I think that we need to understand, I guess, each of the groups so that there is an inclusion group stream of healthier and fairer. But ours is much more about socioeconomic exclusion. For instance, that immunisation pilot, what we know is that within certain communities, there's much higher vaccine scepticism. So, for instance, in Sunderland, during COVID, we got really good immunisation rates amongst the Bangladeshi population who've been a part of Sunderland's community for, decades and decades, because of links into the local mosque and local religious leaders, and going to the Bangladeshi centre to break down barriers. But we found amongst the African community, where I think it's a more recent community, and we didn't have that same route into their community leaders. I don't think we recognised early enough, say, for instance, the impact potentially of the church, because that's often a big community, a resource for the African community. So I think you've got to understand the complexity of the different groups who make up our population. But 43% of Sunderland's population live in the poorest 20% of the country. In Teesside, somebody mentioned it's 57%. So we've got to understand that really we think of people as minority communities, but some of these minority communities are actually a huge part of the population. And yet there are more discrete, smaller populations. And obviously the local authorities are much more advanced and much more aware of the different barriers that need to happen. And I think we've got a lot to learn from the local authorities over stuff like that, public health departments.
Well, I think everybody would say that's been an absolutely fantastic presentation, and we've grilled Martin. We've asked lots of questions just to do a further deep dive. I could go on for probably another hour, but Martin has to dash off, and we've got other presenters. We do have a couple of other questions, Martin, so we'll drop them on email so we can get back to those who've passed them on. But we've had quite a few thank yous as well, so I think people have found that really interesting, and it's just given them an insight into some of those challenges, because I think we probably don't understand enough about that network or even core 20+5 for some people. So that's been really brilliant. So I would like to thank you personally for joining us today. That's been absolutely brilliant, and we'll follow up, and we will hand over to Julie now. So thank you, Martin.
Thank you. Thank you, everyone. Bye now.
Bye. Thanks, Martin. Hello. My name's Julie. I'll just get my presentation up. I'm a poverty proofing health coordinator for a charity called Children North East. And so we're going to thank you very much for inviting me here today just to talk a little bit about the work that we do and the reason that we do it, really. So I do very much appreciate everyone coming and taking the time to listen today. So thank you for that. It's just loading up. It should be on any minute. Hopefully you can see. If you've heard about the work that we do, I will just go over it really briefly. So apologies if you have heard a little bit about the work that we do. But I just thought, so everyone's on the same kind of starting page, I'd give you a brief overview just to understand a little bit about what poverty proofing is, if you've not heard about it before, if that's okay. So yes, I'm a poverty proofing coordinator, so I'm going to explain a little bit about what that is and what that involves. So basically, poverty proofing is a consultation methodology. And what we do is we identify the barriers that people living in poverty face to fully engaging in healthcare. And the way that we do that is by listening to their voices, listening to their experiences. And by doing that, it really offers healthcare settings a pathway to address those often unseen inequalities within the activities, helping to sort of break the chain and the link between health outcomes and financial background, and to kind of remove stigma as well for people who are experiencing poverty as well. Currently, we're part of the North East and North Cumbria ICB's Healthier and Fairer work stream, and poverty proofing has 3 different strands. There's the school day, culture, early years and arts, and health. And we are the baby of the family, really. We've been around for around 3 years. So that's a little bit about what we do. So if a healthcare setting comes to us and asks us to do a poverty proofing audit, what would that look like? Just to give you a bit of an idea about what we would do. So basically, we do provide a bespoke service because each service and setting is different. But this is kind of broadly what it would look like. So we start off with training and initial staff consultations, and that's usually ideally a 3-hour training session for staff, which includes things like poverty awareness, causes and consequences of poverty, poverty and health, that sort of thing. We also do scoping, which is basically information gathering, talking a little bit more to staff, just getting an excuse to be nosy, really, look on websites, find out what buses come and how expensive is the cafe, that kind of thing. But the main part of our work is really conversations with patients. It's really important to note that we speak to all patients that we possibly can. We definitely don't want to kind of approach patients that we think are experiencing poverty only, because that would stigmatize them and single them out, and that's not what we're about. That's not what we want to do. So that's the main part of our work, is just chatting to people about their experiences of healthcare, about barriers that they have experienced to accessing that healthcare, and to learn a little bit more about their situations. If it's appropriate, we will carry out some community consultations. So we have poverty proof GP surgeries, a deep end network actually as well in South Shields more recently. So we would do consultations in the community for things like that, but with poverty proofed 6 paediatric diabetes services, it's much harder to do community consultations for things like that. So then once we've carried out all the consultations, collated all the data, what we do is we have a meeting with the service, basically the managers of the service, the main sort of players, and we have a feedback session with recommendations, and that's quite collaborative. We'll work together on that. And then we will write a report with suggestions and recommendations to remove or minimise the barriers that people have told us about. Then the service get the report, and then around 9 to 12 months later, we come back and we do a kind of a check-in, a review to see what changes have been made. And that's always really encouraging. I do a lot of the reviews, and services have often done so much work that it is really, really encouraging. It's a real positive thing to do. And that's just a snapshot of the work that we've done so far. We have done more than this. Obviously, it's not exhaustive, but those are the sort of settings that we've worked with. And as I said, it's not just in the North East and North Cumbria, it's all across the country and in Wales as well that we're doing work too. So why do we do this work? Why do we, what is the point of poverty proofing? So the reason that we do this work is because in the UK, the poverty line is defined as having an income of less than 60% of the median household income for the UK. Now, the median household income means half of the people earn more and half of the people earn less. So it's that middle income. And that's around £34,500 a year is the median household income in the UK. That's after housing costs. And the poverty line is around an income of about £20,400 a year. And currently in the UK, as of the end of 2023, there were 16 million people who are below the poverty line. And breaking that down, it consists of 9.2 million working age adults, 5.2 million children, and 1.5 million pensioners. Now, recent research has found that an additional 3.2 million people in the UK are only £40 away from the poverty line a week. And there are currently 3.8 million people that are considered destitute. And 1 million of these are children. And destitution means lacking things like a home, a bed, appropriate clothing, food, 2 meals a day, not having 2 meals a day for 2 or more days a week, not being able to light your house for 5 or more days a week, or heat your house for 5 or more days a week, and not having access to toiletries like a toothbrush, soap, that sort of thing. So that's basically why we do the work that we do, because we know there's a link between poverty and poor health, and it's really well known. We know that living in poverty has a profound impact on how people use health services and NHS services and how it affects their health. And poverty increases the prevalence of a wide range of diseases and makes it harder for people to access services. So this lack of access means that people living in poverty are getting sicker and accessing services later. We know that A&E attendances are nearly twice as high in the most deprived groups, and emergency admissions 68% higher. With greater illness and less access to care, this contributes to those worse health outcomes. So men living in the most deprived areas can expect to live 9.7 years fewer than men in the least deprived areas, and women 7.9 years fewer than those in the least deprived areas. So it has a massive impact on the whole of a person's life. It's not just economically not having enough money, it affects how long a person can live as well. So in the work that we've done, we have identified some common themes, some common barriers to access and health services that people have told us about. So we call them common themes, and these tend to come up consistently when we do poverty proofing audits. And they tend to be around travel, as you would expect, affordability, getting to locations, not being able to sort of have the money to get the bus there, navigating and negotiating appointments. There's a lot around sort of hidden costs, how much money are people losing if they have to go to an appointment, are they having to miss work, miss school, that kind of thing. How difficult is it to refer people in? Is it a complicated process? Patient empowerment. So we talk a lot about consistency of care, the opportunity to participate in SHAPE services. We already talked today about the inverse care law. Staff awareness and guidance. It's that kind of knowledge and awareness of what's available to support patients more holistically. Signposting and referrals, joining up with other partnerships and agencies. Health-related costs. It's a cost of health prescriptions, specialist equipment and food, and related activities. And in terms of communication, we kind of look at digital exclusion in that category, as well as health literacy you know, preferences, language and cultural support, that sort of thing. So I thought we have looked at a lot of different areas where we have a lot of different services where there is quite significant digital exclusion, and we know that poverty can have an impact on people's access to digital health tools, because individuals living in poverty may experience that digital exclusion because they haven't got the devices and they've not got that necessarily got the levels of digital literacy that more affluent people have. So the move towards digital healthcare, it can be brilliant, but it can also create barriers for certain groups, including minority ethnic groups, the elderly, and those with low socio-economic status. And that's comes out through our work as well. When we speak to people, that's what they tell us. You know, the digital divide can exacerbate existing health disparities, making it hard for these populations to access necessary healthcare services. In 2023, the Digital Alliance did a poll and found that approximately 13 to 19 million people over the age of 16 are experiencing some form of digital poverty, and people who are unemployed are 2 to 3 times more likely to be in digital poverty. And digital exclusion is now recognised as a social determinant of health because it directly impacts a person's ability to manage their well-being, because it limits access to online resources, online services such as appointments and health information. So what I thought I would do is just chat a little bit about some of the services, well, basically one service that we've looked at, one area. So we've done a lot of work with paediatric diabetes services. As I said, we've poverty-proofed 6 different services. And access to diabetes technology is amazing. It empowers families, it improves health outcomes, and enhances the quality of life for children with type 1 diabetes. Continuous glucose monitors monitor blood glucose levels without the need for regular finger pricking. Insulin pumps administer insulin without the need for injections, and hybrid closed loop systems work together via a computerized algorithm held either on a pump or a smartphone app. And they continuously use the data from the CGM device to regulate insulin delivery via the pump. So they're brilliant things, and they really sort of minimize the stress on families as well, and on children and young people with type 1 diabetes. It is an area that it has been flagged up on the Core 20+5 NHS England sort of strategy to tackle health inequalities, and because it's one of the areas with the greatest health inequalities, it's one of the 5 clinical areas. And NICE, I'm sure you might be aware, it was in the news back in December 2023 a lot, but NICE guidance has recommended hybrid closed loop systems for managing blood glucose levels for children and young people with type 1 diabetes. And that's going to be rolled out over 5 years. But from the work that we've done, we've found that children, and also this is borne out for the National Paediatric Diabetes Audit data for the Royal College of Physicians, so the RCPCH. So what we found, and what obviously is also being discovered by other sort of organisations, children from socially deprived areas and minority ethnic backgrounds have lower access to diabetes technologies like the CGMs and the insulin pumps. And some of that is due to the cost of devices and the necessary mobile data that's needed to kind of manage the apps that manage the devices. So these are just some of the things that people who we've spoken to about technology and why they're not using it, or why they find it difficult, or why is a barrier. This is some of the things that people have told us. So in our work, we found families weren't able to access pump therapy or continuous glucose monitors, because you do need that relatively up-to-date smartphone and data to manage the apps that control the devices. Parents can also follow their children's their CGM, their sensor, so they can monitor their blood glucose levels while they're not with them. And they do need up-to-date phones to do this, and they can't always afford them, or they might not want to get an up-to-date phone for a 2-year-old. It can be really difficult because children can be diagnosed, but obviously very young. Some families also told us that they really struggled with technology generally, but diabetes technology in particular, it is quite complex. And those in poverty are much more likely to experience digital poverty and low levels of digital literacy and need more support to understand how to use that technology. So as I said, that's just a snapshot of some of the things that people have told us about why they haven't been able to access that technology. So we poverty-proofed a paediatric diabetes service in Hull, and this was way back in 2023. And the work that we did with the service, we came back and we did a review, and what we found was kind of encouraging, but what the service found was also a bit upsetting for them, but it did open their eyes a lot. So the service did have, from the National Paediatric Diabetes Audit data, they were aware that it had significant disparities of diabetes technology for families with a lower socioeconomic status compared with those more affluent families. So they were aware of that. They weren't sort of doing very well when they got their data back, and when they compiled the data and sent off, they knew this was an issue. And what they said was the training really helped them to recognise that obviously this was an issue, but also that there was some form of unconscious bias from staff, which was really affecting clinical decision making, because basically they were hesitant to start families who were from a lower socioeconomic status on technology because they thought they wouldn't be able to cope with it. Plus, they also had this unwritten rule that if families didn't have the facilities to download the readings, having the technology wouldn't help them anyway. And since sort of we did this work with them, one of the sort of upshots was that staff now start all patients on a continuous glucose monitor within 3 to 6 months of diagnosis. So regardless of sort of financial background of the family, and they do more work with the families now to ensure that they're comfortable with the technology and they support them with the technology. And the team have also begun opening up a dialogue around finances with patients' families as well. So they will talk to them about those barriers, finances, so they're able to identify potential issues with sort of starting them on any form of technology. So that's sort of a good outcome from the work that we've done as well. So I would say we have, as I said, I just chose pediatric diabetes, but I also had in my presentation about Badger Notes, the maternity app, about working GP surgeries as well, and the work that we've done there, and the access to appointments, everything being sort of more digital. But yeah, I could only choose one in the time that we had. So our top tips are things like building links with charities such as the Good Things Foundation, supporting children with diabetes and family fund for access to mobile phones and data for those who can't afford them. They're a great they're great charities who can really support families and individuals as well. We know the Good Things Foundation has supported Northumbria Healthcare Trust maternity services by providing phones for them for women who are pregnant who haven't got access to mobile phones. But we also know the Good Things Foundation supporting children with diabetes and families fund do provide mobile phones and data as well. We would always recommend making links with local libraries who deliver beginner online courses to refer patients to, and get support with online systems, because we spoke to so many people who were really reluctant to use technology, who didn't really know what they were doing, really just wanted to talk to someone or do something face to face, and to really sort of help them and support them to build that confidence. That can be a positive thing to do. Another thing I would say is that if patients are required to use digital technology to support their medical condition, really make sure that they understand how to use it. That might seem like a really obvious thing to say, but especially with the Badger Notes maternity app, people just had no real guidance how to use it. They weren't sure how to use it. They didn't know what they were doing, and they barely used it, only used it really for appointments and things. So they weren't using it to its full advantage if they were able to use it at all. And some people just said, oh, I hate it, I don't use it. And really to continue to make sure there are other ways to communicate that are outside of those digital or online options, because some people just really struggle. You know, you might have a family that has one phone between everyone, or a pay-as-you-go phone, so it's much more difficult for them to be able to sort of call a GP surgery or call to say that they're going to cancel their appointment, especially if they're on hold, because they just haven't got the money to be able to do that. I would say our main takeaway isn't technology related, but it's really about doing your bit to support patients experiencing poverty. At Children North East and in our poverty proofing team, we really believe that poverty is everyone's business, everyone in the NHS, everyone working in healthcare. And I would say our main takeaway, especially for clinicians, would be to ask people about barriers to accessing the services that people experience, ask about their financial circumstances. You know, don't ask them what they earn or for bank statements or anything like that. And we're not expecting healthcare professionals to be financial advisors. But it's just things like, how are things financially for you? You know, we know having a baby, having type 1 diabetes, having a medical condition is really expensive. Is there anything we can do that can support you? And in our experience, 99% of patients will really appreciate being asked those questions and be willing to chat about them. And Dr. Sanjay Gupta from Hull, who is the consultant paediatrician there, who we did the work with at Hull Paediatric Diabetes Service, said everybody needs to be part of the process of asking the questions, because we all get too focused on the medical aspect. And so it's really about thinking, you know, what are the barriers to patients, especially those who are experiencing poverty? What can we do to support them? And how can we make a difference? And how can we look at it more holistically? Because, you know, we've talked about the social determinants of health. The Dr. Ian Sinner from the RCPCH said the NHS really only has an influence of around 15% of people's health outcomes, and the other 85% are those social determinants of health. And those are the things that people need a lot of support with, as well as those medical issues. So thank you for listening.
That was great, Julie. We've got a few queries, so we'll move on to our queries. But that was really excellent.
Oh, thank you.
So just bear with me all. I'm going to put a spotlight on you. If you want to stop sharing your slides.
Yes, I will. I'll stop sharing.
That would be great. So I had wrote down top 3 tips, but I will probably ask you the top things that the audience will take away. But I'll ask you that at the end. But then you put a slide up with all the tips in, so we'll come back to that. Don't worry about. So Mike was asking about, is there an overlap with Healthwatch with what you do, and do you work closely with Healthwatch?
So we haven't done lots of work with Healthwatch, but we are, you know, we are very aware of Healthwatch. We have done some work with Healthwatch, but not loads. We've kind of looked at how we can work together, and I think we will work together more in the future. I suppose our work is very service-based, so it depends where we're asked to do the work, whereas obviously Healthwatch is kind of universal, I guess, universal based, whereas obviously we are going into settings to speak to people about particular experiences of particular services. At that time, it's kind of like a snapshot in time of how a service is and how people's experiences are. So yes, a little bit, and we have had a couple of meetings, especially in Teesside, but nothing kind of.
That's the Teesside areas. That's perfect.
Yeah.
Pleased to hear about them. That's great. Now, one of the things you talked about was, you know, you go out and informally chat to people to try and gather that information. But one of the people have been talking about kind of language barriers. Do you use interpreters to do that? What's your method?
So, so generally what we would do is we would go into a service. So say we've been working with the specialist weight management service in Teesside and going to lots of different places recently. And basically, if we go to a setting, we'll talk to people who are waiting in the waiting room, or they might have gone in for their appointment, and the clinicians might ask them if they're happy to come and talk to us. So we might be in a kind of side room. And if they do have an interpreter with them, then we would definitely, obviously, utilise that interpreter with them. And we have done that for various maternity services and appointments as well, especially when we did some work in the Northumbria Healthcare Trust. So yes, we do utilise interpreters to get that information. And we have gone to, in South Shields, we went to Apnagar, which is one of the sort of women's services for minority ethnic groups. And there were lots of interpreters there just to speak to the women in South Shields about their experience of getting appointments in GP surgeries and things.
Yeah, because quite often those groups of patients are not always heard, but actually it's the biggest group of people we need to reach, which I know Martin touched on as well, but I think that was a really good question to ask yourself as well. We've got a question from Sarah. Thank you for sharing all of the good practice. My question is, how easily is it to use the same apps and digital solutions to manage other comorbidities that the patients may have? For example, the diabetes review and annual asthma check, or similar, so that the patient can see overall progress of their health. Now, might be too big a question, because that might be trying to solve the world, but I guess it's trying to say how easy it is to support people if they're using one application to use other applications.
Yeah. I mean, I think the key is to kind of work with people to ensure that A, they've got the technology in the first place, and so that they're going to get the best treatment they can, and B, that they know how to use that technology. As I kind of said in my presentation, yeah, the key is ensuring that people can access it, but not just. So it's not just obviously being able to access it on the phone, but actually knowing how they're able to use it, to know fully how they can use it. And obviously, if you can use a joined up app, then that would be less to learn, I guess, wouldn't it? But, you know, in paediatric diabetes, we've spoken to lots of people who perhaps have more than one child, and you can't use the same apps for carb counting and things, because if they both have a CGM and a pump, you have to use different ones because of the Wi-Fi, it confuses the pumps and things. So it is quite complicated and complex. So yeah, the easier the better to support people, but it's just having that, making sure patients have that really good understanding of how to use the technology that they've been given. I think that's kind of key, and having access to it and knowing that. So we're doing some work with the RCPCH around paediatric diabetes, which is, I guess, why I was talking about it a lot. But you know, it's also recognizing that people who perhaps don't have the digital literacy will need more support to understand and use the technology. We had one nurse say, well, you know, I can start a family on a pump in like 2 weeks, but if it's a family who needs more support, it might take me 6 weeks, and that impacts our numbers. So it's kind of
being aware of that and allocating that time. I understand that. And you touched on earlier kind of like the 3 different groups. You've got English not your first languages in migrant populations, you've then got kind of the socio-economic, and then you've got the elderly. And whilst I think we've got these high resolution technologies that have to have a smart device, so you can't have this insulin pump and a continuous monitor unless you've got that phone. But there are other lower level solutions. But I guess one of the questions from Mira is, do we still offer, and do you see that when you're going out to practices, alternative methods where somebody isn't digitally enabled or doesn't have the means to do that? Or are you seeing that more of a divide because we're pushing everything on digital and that we're leaving these people behind? What's your thoughts around that?
Yeah, no, that's a really good question. So definitely in maternity, because we've poverty proofed like 7 maternity services now. So if you don't have a phone, like I said, Northumbria Healthcare Trust have partnered with Good Things Foundation so they can provide a phone. But if women don't have a phone, they do have paper notes. So they still provide paper notes and leaflets. They often use the Best Start in Life team to support people who are from minority ethnic groups, to make sure that they fully understand everything that they're being told, have the leaflets in their primary language, so that they have as much information and efficacy over their care as they can have and should have, as they should. And also, so those things are there. Obviously, diabetes, it is more of a divide, because you do need that up-to-date, those up-to-date mobile phones, so that either I know with the CGM they can have a reader. Some companies, CGM companies, give a reader out, but you can't follow your child's sort of sensor on that, so it's not as effective really as the phone. And certainly in GP practices that we've looked at, we've spoken to a lot of more elderly people who have really struggled with that technology, who have had to kind of, all of their prescriptions are online, they don't really know how to use them, have to ask family members to get, to order them for them. And it is a bit disempowering, I think, for people if they feel that they're not able to do that. I mean, some elderly people are absolute whizzes, they probably know more than me, but but some do really struggle with the technology and not being able to just talk to somebody and ask for a leaflet or be given a leaflet to take home or be given information. So so I think services do try to put things in place, but certainly in the work that we do, when we highlight these things as being barriers, they do tend to be more aware of it, and they do tend to try and put other things in place as well, to support those patients who don't have that digital literacy. Yeah.
And the final question, I'm paraphrasing Mike's comment around where the support comes from. So, you talked about somebody might need more support and longer support.
Yes.
Is that something that you would recommend if you did the audit, if you're seeing gaps and things?
Yeah.
Where does the support come from?
Yeah, so I would say sort of definitely around pediatric diabetes, the support would be the nursing team. So we would recommend that the nursing team spend more time with those families to ensure that they really fully understand exactly how to use the technology, and that they're not just kind of giving them a general pump start session and then a bit of training and then sending them off thinking that they know exactly what they're doing, because people often who are experiencing poverty, they don't always have amazing self-advocacy skills, as a lot of people don't when you're faced with medical professionals. And if you're in a like an MDT meeting, you might not kind of stand up for yourself as much. So they may say, oh yes, I know how to use it, I know what I'm doing, but then have a lot of problems, but because they haven't been confident enough to say, oh, I don't really understand. So I would definitely say that that's an issue. In terms of sort of the other work, like badger notes and things that we've come across more, I would say that it's just, working out how to use it, because they're just told to look at this app, here's this app, download this app, do this, do that, and they're expected to know how to use it. But so many women just had no idea what they were doing on them. And we did recommend like making a video as well, so people could kind of follow like a step-by-step how to use it, because they just weren't being shown. They couldn't find things. It doesn't notify you if your appointments get changed or cancelled. So women turn up at the appointment that's on badger notes, but then it's been changed, and so then it's not the right time, or it's actually not even there, so they've missed work, or or had to get childcare when they've not, the appointment's been cancelled. So it's kind of things like that which aren't sort of the most user friendly, and it's just so that people know exactly how to use it. If you're expecting someone to use something, to really make sure they know how to do it, really. Yeah, has that answered your question, Mike?
Well, hopefully it has, and I guess it's up to the services, isn't it? One of the things
we do make lots of suggestions. Yeah, we make lots of suggestions about what services can do to sort of better support their patients, and just ask, do you need a paper leaflet? Do you know what I mean? It's like, it's not rocket science. Is it better if you have a paper leaflet, or can you access this link online or scan this QR code? So
I think for me, I know Teesside with Grace Murray, with the whole digital inclusion, and they got some funds into from the Northern Gas Network, I think it was, to look at something specific around digital inclusion with obviously pregnant ladies and newlyborns. So I think that there is some really good practice, and one of the things we're working on as well is how do you get the right technology to the right patient, and how do we repurpose working with our trusts best to try and support some of those barriers. But we will provide an update probably at the next session on that one. Now, I would love to chat further, Julie. It's been really insightful. I know you're jetting off to London tomorrow, so we're really grateful that you've been able to join us today. I'm sure everybody's got lots out of that, and we have got a couple more questions in the chat or some comments, so you'll get those afterwards and we'll be able to follow up as well. But we're going to hand over to Chrissy now, so I will thank you very much, Julie, and pass over to Chrissy.
Hopefully I will share the screen and hopefully everyone can see the Learning Academy page. So we have launched a digital inclusion area on the Boost Learning Academy on the 26th of February. It's still in its infancy. We're still adding to it daily, but it does have all the information that you need there. The Boost Learning Academy was chosen because it's free for everyone to access, whether you're within the NHS or a charity or education. You just have to pop your own email address in and you're ready to go. So we're found in the programs section. We're currently down on the second row in the middle because it's currently in alphabetical order, but I do know that they are developing the websites that it appears randomly each time you go in, so that it doesn't seem like one module has more priority than another. We've got a nice helpful video on the right hand side that shows you how to navigate the Boost platform. So I'm not going to play that today because it's a bit too long, but that will help everyone navigate it. And our catalogue currently consists of 4 things. We've got NENC ICS projects, digital inclusion stocktake, digital inclusion tools, and as of today, we have the digital inclusion forum. So we will be hosting previous recordings of the digital inclusion forum on here so that anyone can access it. The NENC ICS projects are the projects that we as a digital inclusion project management office have funded as part of the digital inclusion program. We've got 2 different types of modules. We've got live events and e-learning. Live events just show you information. E-learning gives you documents to look for. So for instance, if we go into video conferencing, we've got all the information here, the summary of the project, who the module is for, learning objectives. But if you scroll down to the bottom and you press register now, you then get the document. So this is the report of the finding of the project. And if we just click on this one, you can read here and you can read the report that was created from the project. Go back here. Oh, where's it going? There we go. A nice technical difficulty there. We'll go back here. We'll go to digital inclusion stocktake. One of my favorite ones on here, the digital inclusion stocktake, is something that we've asked the community to fill out. So we have a digital inclusion stocktake form where we encourage people to send in and submit the digital inclusion projects that they are working on. It can be a project that has finished or a project that is going on. But my favorite is digital inclusion in maternity because they've actually got a video as well, and it describes the whole maternity project. And down the bottom, we can see what digital inclusion domains it reaches, as well as the areas. The maternity project covers the whole of the North East and North Cumbria. We've got in digital inclusion tools, as I mentioned, we've got our digital inclusion stocktake. We have a Word form and a Microsoft form for people to fill out. So if Microsoft Forms is not your thing and you'd rather fill out a Word form and then shoot it to us by email, you can. As we said, anyone can fill out the form, and if it's a digital inclusion initiative that we think will fit with the region, we can add it onto Boost. But the main thing that I'm here to talk about today is our digital inclusion forum. So we've got 2 sections in it at the moment. The digital inclusion module overview, where we've got all the information of the upcoming 3 digital forum events, an overview of what the project is for, and down here a link to learn more about HiNENC and the digital inclusion forum. And then if we go back again down the bottom, we've got last month's February's recording, and here we've got the recording which you can blow out into a bigger screen, And then we've got all the presentations that were in the last presentation and any subsequent information needed for it. And that is Boost.
Oh, Chrissy, that was great. Thank you so much. I forgot to put my mic on. It just helps, doesn't it? That was, it's great to see content adding to continuously, everything in one place. And I know that over time that will just become richer and richer in terms of its content. And it's great to see that actually digital inclusion has a place. That we can kind of direct people to for one version of everything across North East and North Cumbria. So I think that's absolutely brilliant, and really like to publicly thank you for all the work you've done to make sure that the stuff that we're doing in the background also has that visibility. So that really helps and the people who are a part of our membership, but much wider than that as well. And one of the questions I think that Leanne has already answered it is Mike is a volunteer and he's saying, is it okay for him to sign up? Is it freely available to volunteers as well as charities, etc.?
Yep, anyone can sign up. It asks for an email, and when you sign up, I think you have to put in like what industry you're in, and it's all for tracking on the Boosts end themselves. But you can sign up and you can access not just digital inclusion, but you can look at any of the things that are on there. I know that poverty proofing does also have a module on there, so if you want to go and check that out as well, you can.
Yeah, I've seen that, which is brilliant. So yes, Mike, and please share onwards. We have included it in the chat, but we will also include it in the email that gets circulated about a week after our event, just so you can see and get access to be able to register. But I think it's a brilliant learning platform and information resource. So that is brilliant. If anybody's got a project they're working on and wants to include it, they would just fill in either the Word form or the MS Forms form. Is that correct, Chrissy?
Yep, just fill out the form. I will send it out after this as well. So they've got the Word form and the link. But yep, just fill it in. And once you've filled it in, if your project has an update, feel free to fill it in again and we can just update it afterwards. You don't have to do it once and then just leave it. You can send as many in as you want.
That's brilliant, because I think it's a great place to be able to store, because there's so much good work happening across our region, but we don't always have visibility of that. So I think it's great that we can kind of encourage, our member participants to be able to send in things. And then, to me, it's all about spreading adoption. How do we encourage others? What are those top tips? How do people learn? How do they make a difference to the lives of the people that we serve across the region as well? So that's brilliant. Thank you very much. The only thing I've got a query from Mira is thank you. She can't wait to check it out, which is fantastic. So we've got another one signed up there. But is the digital inclusion stocktake data available for researchers and public, please? So I think you'd have to go back from a GDPR's perspective to find out about that. But
I can certainly go and check. But yeah.
Yeah. And then if you drop an email over to Leanne and she can get in contact with Mira, Mira will give us permission just to be able to share anything. But I think that's, it's great to see that there's data around, isn't it? And it's what you can do anonymously to be able to provide that in terms of demographics, etc. That's fantastic. Well, wonderful. Well, if there's no more questions, I will let you drop. Well, I'll let you not have to speak anymore or get grilled by me, Chrissy, which is always a good thing. And it's just a final few comments from myself. Is we are looking at the next Digital Inclusion Forum, which is in June, covering the topics of health inclusion. But also the ICB are about to launch their digital inclusion strategy. It has been slightly delayed just with other things that are going on, but we are hoping they're able to come along in June and give a really good overview of that document and how that looks. So I think that's going to be a great chance for everybody to have a read, but also think about how does it impact me and my work area, and what are the things that can fall out of that. It's got some great things in there. I've certainly seen a draft version of it. Some of the things that we're doing across the North East, as well as the things Chrissy has touched on in terms of the website, where there's been 7 projects ongoing. So some of those are weaved into there as well. So we'll let you know about that. And we're hoping John Quine will join us around health inclusion from a different perspective, who's always a great presenter, full of energy, and anybody is welcome to join, as you would know. The final thing from me is we will probably do a bit of a brief update on the device repurposing. So that is about how we don't leave anybody behind and how we get devices to people, just to give you a position statement as to where we are, our challenges, and also how you can help us to unpick some of those challenges as we push forward. So that's the top 3 things. I'd like to personally thank Martin, who's not with us now, but Julie and Chrissy for 3 fantastic presentations. We've covered, you know, poverty proofing, which was fantastic, a really good link to the Deep End network, as well as the Health and Growth Accelerator. So that was really fantastic to hear some of those things that Martin was talking about, but also how all of that information is now starting to pull together with the hard work from Chrissy and the team in the background on the Boost platform. And that's really nice to see that come to life. And as always, thank you to everybody who has joined us. I know some people have had to drop off. I think it's been a really great, insightful session. It's always good to see everybody, and we look forward to you joining us in the June session. But take care in the meantime, and please enjoy the sunshine and stay safe. So thank you. Take care.